I'm so glad everyone's joining us today. All right. Wow, everyone's on time. This is great. Thank you, everyone, on a Friday. Okay. Cool. Okay, so I'm going to go ahead and get started with our introducing our guest today. Welcome to this month's presentation from the Partners in Care Community Education Series. I'm Joelle Blanchard, and I am your host. Today we have a special guest who is joining us all the way from Utah to discuss a topic very important to many of us in the Central Oregon community: how to solve the issue of needless suffering and deaths on the streets, and ways to support a dignified, sheltered end of life experience for those experiencing homelessness. So before we get started, we just have a few housekeeping items. You are all muted. You don't have video capability. And then if you have a comment or question, please use the Q&A feature, and we'll be checking the comments and questions throughout the program, but we hold the exchanges until the end of the presentation. So I'd like to introduce Jillian today. She is a mother of 2 and a military wife of over 21 years. She has developed an appreciation for the mission of the in-between after her mother and father were placed on hospice before passing. She started as a volunteer for the in-between, transitioned to a full-time employee, and served as HR and operations director before being promoted to executive director in 2022. So Jillian is dedicated to the mission and believes that together we can prevent needless deaths and suffering on the streets of our community. So with that, Jillian, please go ahead and get started.
Thank you so much, Joelle. I'm going to share my screen. I have a presentation for you guys. And is that sharing?
Looks great.
Okay, thank you. Thank you so much for this opportunity. We love sharing our mission, and our dream would be that there is an in-between in every major city that has a need for it. So we are a facility that is providing a place between someone receiving care or not, someone receiving cancer treatment or not. We are the place between someone experiencing a dignified death or dying alone on the streets. This is our residents' home. This is their address. They need an address to receive hospice care or cancer treatment, or to receive a major surgery. So above all, we're their address and a place to call home. That was a quick video that had several of our former residents who received our services here. So in Utah, we have 75,000 individuals experiencing homelessness. It's hard enough to be on the street when you're healthy, let alone when you're sick. So the Utah Office of Homeless Services strives to work together with communities to make homelessness in Utah rare, brief, and non-recurring by providing statewide supportive project services, interventions, and system performance measures and reporting. This is an image from Salt Lake. We've definitely been on the news for some of our encampment abatements. And imagine dealing with a cancer diagnosis or experiencing end of life in a tent during one of these abatements, being shuffled throughout the city. Or suffering through a cold winter exposed to the elements. So this is exactly why we're here, to provide medical respite and end-of-life care for people experiencing homelessness. So who are we? We're a part of a continuum of care for the Greater Salt Lake Valley, and medical respite care clients will ultimately be discharged back into the community. Our goal would be discharged into some sort of permanent housing or reconnecting them with family. We do not want to discharge people back to the streets, but sometimes there is no other option. So we have 25 beds licensed as an assisted living type 2 and 25 beds as independent care, which can also be called eleemosynary beds, which that term was coined by the Ronald McDonald House. So think of those individuals as being able to take care of their daily activities of daily living, like med management and toileting, but they just need a place to stay while recuperating from maybe knee surgery or an amputation, or so their wounds can heal, or so that they can qualify for cancer treatment or other life-saving treatments. I want to share just a quick story before I dive more into what we do. So we had a resident named Ketra. He was a 40-year-old male, and he came to us being homeless, and he was having a hard time taking his medications, and it was severely affecting his health. He was admitted to hospice care in our facility, and we were dedicated to help him manage his medications correctly so he would be comfortable. There was a significant improvement in his health after being here. He was discharged from hospice. He moved on to our independent living side. He was heavily case managed. We discovered that he was unable to read, and one of our residents, Kimberly, helped him with literacy, and over time, she taught him how to read, which increased his vocabulary, which in turn also helped him with his medications. So during his time on the independent side, he worked closely with one of our community partners, Volunteers of America. He was able to receive stable housing and was a very positive discharge for the in-between. And it really shows how working together with our partners can create a really successful change. Someone who was hospice, less than 6 months to live, and is now living independently in housing. Who we care for. So the perfect admit for us is someone who is 18 years or older. They're experiencing or facing homelessness, and they're suffering a medical crisis. So this person may be end of life, or they may be needing recuperative care along with a life-saving treatment. So what do we provide? We provide medical respite care and hospice care. So again, we have two sides to our program. People may come in on end of life, and they are receiving outside care from a hospice agency and being seen by our RN and our 24/7 case management team. Medical respite is people that we hope will be leaving the facility after a short stay with us. It could be just a couple of weeks or a couple of months, and they will be able to leave our facility much healthier than they came in. So since we are a licensed assisted living facility, there are parameters around people we can take. So we are not a skilled nursing facility, nor are we a memory care unit. So you can think about a hospital as kind of the highest step, and then a skilled nursing facility, and then an assisted living type 2. So there are some people that need higher levels of care that we can't take. So we also are not a detox facility. We are not a mental health facility, and we are not a walk-up facility. Individuals needing those services, we're able to refer them to someone else. They can come to us after detox. They can come to us after being seen by a mental health provider, but we just are not staffed to handle people coming in with those issues. Our building is extremely beautiful. We were very lucky to purchase this facility 4 years ago. We were in a very small old convent and an elementary school. This new building is 60,000 square feet, and we have 32 rooms. Most of them are set up for double occupancy, so we can have 50 people here. If we were to get a zoning change, we could have 72. The rooms all look a little bit different. They have different paint and light fixtures, so they look more like an apartment and not like a hospital room. We provide dignity above everything else. So we try to provide everything for the residents, whether it is having volunteers come in to do haircuts, beard shaves, and also providing them a laundry room so that they're able to continue their independence if they need it. One of the programs we've launched recently is a life skills program. So we have a life skills lab for residents to learn computer skills. They can access their medical records, maybe do some job searching and resume building, or learn financial management, or even just connect with their friends and family members while they're here. Our demographics from the last fiscal year, as you can see, it kind of aligns with Salt Lake's demographics. We're typically seeing white males. The average age is between 50 and 60. The average age for deaths right now for us is about 58, which is very young. And we're providing about 12,000 days of stable housing a year. We have over 6,500 volunteer hours. We had 15 people pass away with us last year and 7 exits to stable housing.
Jillian, we can't hear the video.
Oh, no. Let me see if I can change that. Do you know if it's on your end or mine?
I don't know.
Let me try this. Tell me if you can hear. Did that work?
No.
No. Okay. I can skip that and I will just share it with you guys after. We have a much longer video that this is a clip from, so I can share the whole video after if that's fine.
That's great. Thank you.
Okay. Oh, now it's not wanting to share the next slide. There we go. So referrals and admissions. So to get into our facility, you need a medical referral. So we're receiving calls from our local hospitals about individuals who are either needing to receive hospice services or receive medical respite care. They reach out to our intake coordinator. She receives about 70 calls a day, and she works to prioritize all of these individuals. Hospice is obviously the most urgent, and we try to get those people in as soon as possible. If someone is coming in to stabilize before a surgery, they might go more towards the end of the list and be admitted just a day or two before their surgery. So we offer case management services here. So when they come, we do an intake and needs assessment on everyone. We figure out what we can provide for them in their stay here. We provide transportation to and from their medical appointments. We help with behavioral, mental health, and care plans. And then, like I mentioned, we hope to discharge them to the community, hopefully with a safe discharge into housing or a resource center, or provide them end-of-life care. Our activities program. So we have continually been expanding on our activities program. This is just kind of a sampling of what we provide for our residents on a monthly basis. We do monthly fun lunches. So our residents, staff, volunteers, we all get together once a month, eat lunch together. It's a theme, so people dress up, we play games, we decorate the room. It's kind of a way for just everybody to stop working, stop thinking about their medical condition, and just spend some time together. One of our favorite activities is bingo. That's where you'll find the most of our residents on a Friday afternoon, mostly because there's prizes. One of the new things we've implemented in our recreational activities program is integrating our residents into the community. So from the zoo to the symphony, we want them to be out experiencing these things, and for some of our residents, it's the first time that they've been in these buildings. They've either been sleeping outside of these buildings, maybe panhandling around them. So it has really, really increased I would say their happiness, being able to be feel like they're part of the community again. This is another activity image. I'll just go through a few of them. Some of our residents. Our food program. So we are really blessed by the Utah Food Bank's Grocery Rescue Program. So the food bank goes around to local grocery stores and gets food that's maybe going to wind up in the landfill. It's expiring, dented can, that sort of thing. And they come to us twice a week, and we're able to pull about 90% of our food needs from this program, and it's 100% free. We supplement it with the Bishop's Storehouse, which is a program through the LDS Church. And then also there are some things that we need to purchase on our own. But for the most part, 90% of our food costs are free. This is some of our awesome kitchen team and some images from our birthday lunches. Our head chef, Darren, meets with each resident when it comes close to their birthday and finds out what their ultimate meal would be. It's surf and turf, it's steak and baked potatoes, whatever it is, we're gonna make it for them, and we sing happy birthday to them. We also have therapy animals that come with our residents, and this is a picture of one of our therapy dogs named Mercy, and she was with one of our actively dying residents and really helped calm him at end of life. This is some of our gardening photos and activities. We receive flowers every Friday from Trader Joe's, and residents and volunteers get together and create floral arrangements for the whole building. We have a jewelry making program where residents can make jewelry. They can keep it, they can give it to the facility, and we will have it at our fundraising events. So for a donation, you receive a piece of jewelry made by one of our residents. We have a lot of community volunteer opportunities. This is a local car dealership that came in and renovated one of our outdoor areas for residents for barbecues. We have a NOTA program. This is a nationally recognized volunteer program that offers companionship and support to individuals who are nearing the end of life. So our nurse and end-of-life doula determines when someone would like NOTA volunteers to come and sit with them. We notify our 70-plus trained volunteers, and they can sign up for 2, 4, or 6-hour shifts to come and sit with people, because it's our policy that no one here dies alone, and we probably couldn't fulfill that without these amazing volunteers. People who die on the street don't typically have any way to be memorialized. So it's important to us that when a resident dies, that we gather everyone together and have an honor line when people leave our facility. We also will provide a community memorial if that's something that they wanted. So residents, staff, volunteers, caregivers, if they had any friends or family, they're able to come and speak about that resident and have some closure. And then the final thing we do is we etch their name into our memorial garden so that there is a legacy for them. And that is the end. Thank you so much.
Thank you, Jillian. That just gets me so excited. The folks here who are energized by thinking about really giving that dignity to folks who need it the most.
Yeah.
This just is so inspiring. It looks like we have a couple of raised hands.
Okay.
Let's see here. So Wes, I'm gonna unmute you if you'd like to unmute yourself and ask a question.
Yeah, thank you. And I appreciate the presentation. I lived in Utah, actually Salt Lake for 20 years, so I can appreciate a little bit of your environment, and but certainly the care and love that you offer. I guess in general, I'm fascinated in some ways actually to Joelle. To what degree does Partners in Care are we involved in those who are unhoused? And so I'm curious our perspective, because it's amazing what's going on at the in-between.
It is, Wes. Thank you for asking that. We have, so as a nonprofit, it's just our style to do what's right for the individual. And so what that looks like is meeting each case in a different way. So we have provided hospice we have locally, Jillian, something called Bethlehem Inn, which is a high barrier shelter. And it really does serve a purpose, but it's a group setting. So that makes it difficult to, provide kind of the quiet, just that experience that we want every hospice patient to have. So we've done creative things. We did have a staff member take in a patient at one point. That was very special and very unique. So Wes, to answer your question, I would say that we have Jillian on today in order to kind of get our minds thinking this way, because there's a study up in Corvallis that was just done that our unhoused population is actually getting quite a bit older. So that's something we need to really address in this community. So that's my answer. That's my non-answer answer, unfortunately.
Well, that's all right. I personally, I also volunteer in Bend at the Navigation Center, the low barrier shelter, right? So I do, and so I understand that this is the kind of communication we need in our community, and I appreciate that you are helping that, and also to hear from Jillian today. It provides what a wonderful perspective, and kind of it does. It just informs all of us that the need is there. So thank you.
Thank you, Wes. Okay. Looks like Willow, would you like to ask your question?
Thank you. Can you hear me?
Yes, we can.
Hi, Jillian. Thank you for being here. I am a social worker with Home Health and Hospice, and have watched our homeless population, houseless population expand tremendously as the rest of the country has. And I would love to see, you're a much larger community than us to sustain something like this, but I wonder if there couldn't be something incorporated in our smaller area, because it's definitely, there's a medical need. Funding, how is it funded? Medicaid, or are there other funding sources?
So we are unable to bill Medicaid. There was a medical respite waiver passed in 2021, and it is specifically for medical respite for homeless. And we've been waiting for it to come through the Department of Health and Human Services, but we are very hopeful that we will be able to utilize that in maybe July. That would be huge for us. It wouldn't be all of our costs, but it could be close to half, depending on how much they're going to allow us to bill for. So we are primarily funded by our grant writing and individual contributions. We do have some government grants, and in the last fiscal year, some PPP loans that we received. But yeah, our foundation and corporate grants is about 50% of last year's budget. But yeah, our goal is more sustainable streams, such as being able to bill Medicaid. Right now, we can only bill for New Choices waiver, which someone has to be in a assisted living facility for a full year before they can apply. And that doesn't really align with our mission. Our mission is short-term recuperative care stays. But if we happen to have someone for a full year, which it has happened before, we immediately apply for the New Choices waiver, and then they're essentially funded. It can either help them get an apartment or go to any other facility in Salt Lake.
Is there any chance that that will be amended as far as the New Choices, the year-long wait for somebody to be considered for? Is that a legislative issue, or?
I'm not sure if it will be amended. They did recently pass something. I don't have the name of it in front of me, but they are able to qualify people who are on TAM, Targeted Adult Medicaid, in assistance, so they can get them up to $2,000 to help them get into housing. So we've partnered with an organization here in Salt Lake to help people apply for that, because it could help them with past bills that they have that are preventing them from getting into housing, whether it's utilities or, landlord, that sort of thing.
Yeah. Thank you.
You're welcome.
And just to be clear, I love the slide about what exactly it is that you provide, but when someone needs hospice, you call a third party hospice agency.
Yeah, so in Utah, to be a hospice, it's another layer of licensing. And so we're an assisted living type 2 that can have hospice patients. We just don't have hospice doctors and nurses. So Intermountain actually provides charity care for anyone who's undocumented or unfunded. They will provide the hospice care for them. But people can come in with whatever hospice company they choose.
Great. So Larry, I'm going to unmute you. If you'd also like to unmute yourself and ask your question.
Yeah, hi. Can you hear me?
Yes.
Yeah, this is Larry. I'm a hospice volunteer, but I also run the Cascade Peer and Self-Help Centers. We have two, one that's connected to the Shoes County Downtown Clinic, and then we have one at the Masonic Center. And I just wanted to acknowledge another connection that we have with Partners in Care, that Jody and her staff of nurses picked us. I should mention, we're a low barrier drop-in center for homeless people, and we provide showers and laundry and food and entertainment and activities and so forth. And Jody and her staff of nurses picked us as the nonprofit to support this year, and provided massive amounts of food and supply. So I just wanted to acknowledge that connection between us. And we, in working with Partners in Care, we are to notify Partners in Care of, if we're aware of somebody that's dying on the street, and Partners in Care will step in and provide support for that homeless person.
Yeah. Thank you, Larry.
Thanks.
Okay, looks like we have a, okay, so now I'll go to the Q&A. Wow, I love the engagement. So yes, looks like this question was already answered. How is your facility funded? And boy, that is a lot of the questions here. Do you have in-house grant writers, Jillian?
We do. We have a full-time development officer, so she's responsible for grant writing, working with community partnerships. She also does some lobbying. Right now we're trying to get a chunk of funding for this fiscal year because of our funding gap, because the medical respite waiver hasn't been implemented yet. So yeah, probably grant writing is maybe a 20 to 30 hour a week role in our organization.
Absolutely. It's the lifeblood. It's so important.
Yes.
So another question, can you talk a little bit about your average length of stay, which might not be something that that's hospice terminology, like the average length of stay. So can you speak to that at all?
Yeah, overall for our whole organization, the average stay right now is 80 days. Hospice, it could be one day, it could be much longer. One of the major factors for us is when we're working with the unsheltered population, they typically haven't been receiving medical care. They've been using maybe just the emergency room for their primary care. So sometimes they come to us on hospice and they get better and move on to palliative care and maybe even to our independent side and out, just like we talked about with Ketra. So an average for our hospice is so skewed because they usually will still stay in the facility after hospice.
That makes sense. And that goes to, we did have a question about why seemingly so few folks actually pass away at the in-between. You said, how many last year?
Last year we had 15.
15.
Yep.
Does that seem, because how many residents do you have?
At any given time, we can have up to 50. So COVID skewed our numbers a little bit too, because there were state lockdowns and we couldn't bring people in. But really taking the second half of 2022 gave us a really good snapshot, and that was 91 residents, about 7,000 days of care, 20 were end of life, 9 passed, and 23 residents were exited into permanent housing. So we really stepped up our efforts on permanent housing because the prior year was only, I think it was 15 or 13 total for the whole year. So we're really trying to focus on exiting people into housing if we can. It's not really available. And it takes a lot of coordination.
Oh, so do you have limited housing available?
Yeah, I mean, there's a lot of options, but there's long wait lists and there's a lot of paperwork, and our case managers can help with it. But ideally, we're finding housing case managers in the community that can help so that if they don't get housing while they're here, that doesn't get lost, and they can keep working with them.
That sounds familiar.
Yep, I think that's a commonality that most states have.
So Elizabeth Johnson says, based on what you are seeing in Salt Lake, what are the main obstacles? What main obstacles have been in terms of unhoused accessing the hospice care and benefits?
The biggest thing is you need 2 things to receive hospice care, and that's a physical address and that's caregivers. Those are 2 things that the unsheltered population does not have. So you can't receive hospice care on the street. And sometimes you can't even receive hospice care if you don't have any friends or family that can take care of you in between the visits from hospice care.
Yeah, we see that even with folks who do have secure housing.
Yep.
It is such a challenge. Caregiving is sparse.
Yes. And that would be someone that would qualify for our facility too, because they're facing homelessness. If they're, actively dying in their home, they're going to lose their home, and there's suffering happening there too. So while they may have a home in that moment, that doesn't mean they wouldn't qualify for our program.
Wow. Okay. So a follow-up question. Would you please describe the initial steps that led to the development of the in-between?
Yeah, so I came on board after the in-between had been open for a few months before I started volunteering, but it started with a hospice nurse at our local cancer hospital who said she needed to try and find an in-between. So for people who were too sick to be on the street, but not sick enough to be in the hospital. And she started working with some people in the community. One of them is Monty Hanks. He's actually one of our employees now, Director of Client Services. He had been working at 4th Street for over 20 years, which is a community clinic where the majority of our residents, that's where their primary care is established. And then they started working with the Interfaith Roundtable here in Salt Lake, and it was a lot. They were able to secure a facility through the Catholic Diocese. Mm-hmm. So we rented that facility from them. It was a very small 16-bed convent with, like I mentioned, an elementary school, which we weren't able to use for housing residents because it needed an earthquake retrofit. So we had a huge elementary school with 3 admin staff at any given time and 16 residents squashed into a tiny convent, which is why we started looking for a better facility. But one of the biggest steps was navigating the neighborhood pushback, which was experienced in the In-Between's original location and then also upon our move about 4.5 years ago when we purchased this facility. I think anytime people are facing a major change that close to their homes, there's the fear of the unknown. There was a bit of a battle to win the neighborhood over and really explain to them that everybody deserves this level of dignity. You know, they may not have received it during life, but they deserve it during death. And so slowly but surely, it was about 10 years in the making to open the original facility because there really wasn't a model to follow. And, you know, they had to find the funding, they had to find the staff, the volunteers. So it was a long road.
That's amazing. That's amazing. We have one of our, I say it's one of the jewels in our crown, the hospice house here. And I can see similarities and differences. We consider it a little residential style hospital. It is a very cozy place, but it's for GIP level care. So it was designed to provide hospice. And so the main contrast is your facility is really a place for people to live, and our place is really for someone to live as long as they have. So do you have things like hospital type things? Do you have like oxygen and or is that all just provided by the hospice company?
So we don't have in-house oxygen where you can just flip a switch on, but a lot of our residents are on oxygen, whether it's provided by hospice or home health, or it's being delivered to them because it was prescribed by their primary care doctor. But, you know, we have the normal call light, so think more like a nursing home because this actually was a nursing home before we purchased it. But yeah, we have our 24/7 CNA coverage and an RN and dietitian and all of that for our assisted living residents. Independent care is more house managers helping them and case managers.
So who would you consider? It sounds like you have a lot of relationships in the community, and I'm just wondering, who do you work with? How did you build partnerships? Who are the main players in all of this?
I would really say our biggest partner is the 4th Street Clinic. They've been in existence for many, many years. They're well established. And for someone who's needing medication and doesn't have insurance, they can go to 4th Street, get established care, and then they can get their prescriptions, and, you know, even if they don't have any income. And they work really well with us. Like I said, we need a medical referral. So maybe it's someone who's not in the hospital, but say Volunteers of America's street outreach team is seeing that this person really needs to come to the In-Between. They can take them to 4th Street Clinic, get them established, and get a medical referral from them. So 4th Street, I would say, is the partner we work with the most. And then there's some behavioral places for mental health. Valley Mental Health. Volunteers of America has a detox, and you know, they really have their finger on the pulse of everyone that's on the street. So we can also reach out to them and say, you know, this person's being referred, what do you know about them? As I mentioned, untreated mental health and detox, one person coming in and actively detoxing can take all of our resources, and we're just not staffed for it. So we make sure that we're doing these offsite assessments so that anyone we're bringing in, we can properly care for them.
That resonates. At the hospital here in Redmond, I was just having a conversation the other day about what do you do? Where do you discharge folks? And we have such limited resources as it is in this community. There's really not too much to offer when someone needs that substance abuse support.
Yeah.
We have, very few options. So I do have a question about is it 4th Street?
4th Street.
4th Street.
Yep.
Are they a federally qualified health center?
I believe so. Yeah.
Okay. We have, it's so interesting to compare our communities because Salt Lake is much larger. We have about 1/3 of the unhoused population.
Oh, wow.
Yeah, but still, we're a much smaller community, and we have lots of folks in need. Okay, looks like we have a question. Oh, thank you, Elizabeth. She sent me the link, 4thstreetclinic.org.
Oh, thank you.
Oh, and it looks like we have an answer to another question. Thanks, Lisa. Yes, so we do have a couple of federally qualified health centers. Mosaic is one of them. And we also have the Lapine Community Health Clinic. And those are probably the places that do the most outreach for our underserved communities. And we have been working hard to, first of all, identify what the need is, because it's complex. Where to provide hospice is what is exactly the problem you're solving. And that is a persistent problem that we have in the community. We do have a project coming up called Project Turnkey, which the city of Bend has qualified for, and it will be refurbishing older unused hotels and using, and then the idea is that we can reserve some rooms for medical respite, which would change so much for our community. Do you find that your referrals are more for home health or more for hospice or just more for respite?
More for respite. That's really why the program expanded. It was initially just strictly for hospice, but then it was, I think, a light bulb moment of if there's not something for these individuals now, they're going to wind up on hospice because it's exacerbated when you're living on the streets. So a simple wound from uncontrolled diabetes could lead to sepsis and death pretty quickly. So our mission was expanded to include the medical respite care, and it's the majority of our program. Our main focus is hospice, and they take priority, but the most referrals are for medical respite.
Yeah, so another similarity with us. So how long do people, or is it just case by case, obviously, but how long do you have for respite? Is that a separate process for you?
Yeah, it's case by case, and we base it on what their primary care physician is recommending. So perhaps someone needs to be stabilized before they'll be considered for surgery. So they may have to come and stay with us for 2 weeks and show the stability, and then they qualify for that surgery. And then maybe they need 6 weeks, 2 months, 3 months to recuperate. So it varies wildly.
Okay. Wow, much work to be done. Well, thank you, Jillian. Is there anything else that you want to mention before we close?
I don't think I do. Thank you so much for having us.
Okay, excellent. We have, I think internally, the folks who had questions, I think we might need to have a conversation with our own community about how to respond to this need that we're seeing.
Yeah, feel free to reach out. And I mentioned too, I can send slides and any other links that might be helpful for any of you listening.
Thank you. Oh, one more question. You haven't expanded the in-between, right? Are there other places that are similar?
No, we're just this one campus. We did go from 16 beds to 50 beds when we moved up here.
Okay, and you haven't heard of anything else nationally?
We're pretty unique in offering both hospice and medical respite. You can look on the Omega Network's website for social model hospices, which we are, but we're also a licensed medical facility, which is a little bit different. But you can see some of the social model hospices throughout the U.S. There's not a ton of them, and they're typically, just a few beds.
Excellent. Wow. Okay. Well, thank you very much, Jillian. And with that, I think we'll close. So thank you again for being here today. Next week, look up for a follow-up email, which will include a link to a feedback survey that we would love to have you fill out. It takes a couple of minutes, and your suggestions and comments really help to guide this program. So thank you for attending today's webinar, and I urge you to follow both ours and the In-Between social media accounts on Facebook, Instagram, LinkedIn, and to learn more about this topic and our overall mission supporting the community. Next month is on February 17th, and that will be on Medicare Advantage. So how to look at the options available and dispel any doubts that you have about some of the predatory practices we've seen in the news lately about folks trying to sell Medicare Advantage plans to unsuspecting people. So once again, Jillian, thank you so much. And for everyone who's here, have a great weekend. I hope you get to spend some time with your families, and we'll see you next month. Thanks, Jillian. Bye-bye.